Thank you so much, Lisa. I am so honored to be with you all today. And so it is so good to be here. I actually bring you greetings from Texas today. I'm actually a Louisiana girl through and through, as if you can't tell by my name, but I also reside in Texas. And so I'm really excited to be here. And just a little bit about myself before I jump in. I am the Director of Palliative Care and Social Work at Texas Oncology. And so I have the honor of serving our patients and helping to support our social workers and our palliative care clinicians as we provide services to our patients across the state of Texas. And so I am really passionate about palliative care and end-of-life care in general. I firmly believe that we are living and our quality of life is really important, and all of that really matters until the very last moment we take our last breath. And so part of what I am committed to and really have an honor in serving and sharing space with patients is helping them steward all of that time. And so today we're going to talk about some of that stuff. And so I kind of like to just set the tone and give a little bit of an advisory kind of message before I start. For some people, the thoughts about some of the things that we'll talk about today can feel challenging. It can feel difficult as a people, and I'm going to speak very frankly as people of color. I think we've taken a perception about looking forward, especially if it's about death or dying, as something we just don't talk about. I firmly believe everybody's dying, but nobody wants to talk about it. And literally, from the moment we are born, we are dying. And so part of what I believe is how we steward the life that we're gifted with is also to talk about what that space looks like too. And so for sometimes this can feel uncomfortable. Some of the things that we'll talk about are really can be challenging for some people. But I hope today that you leave with new information, new ideas, get some of your questions answered. I hope to dispel some myths for you all, but most importantly, feel like there's more for us to do. I believe talking about these things helps us be empowered members of the care system and making sure that we can navigate our care with all the tools available. I am the granddaughter of a Baptist preacher. So I also believe in a good amen corner. So although I love the sound of my voice, if you guys, if there's something I say that resonates with you, talk back to me, put it in the chat, tell me that was good, or feel free to say something, nod your head, wave at me. You know, there is no one more affirming than Black women. And so let me hear back from you. I enjoy and thrive off of that. I also don't want this to be a sage on the stage kind of experience. Although I am the person presenting, you all have lived experiences. You all have your experiences within your community, within your families, that I believe bring valuable information to the conversation. So feel free to chime in as well, okay? All right, so I'm going to try to share my slides and hopefully I don't mess up doing that. Let's see. All right, if someone can let me know if you guys can actually see my slides. Perfect, thank you guys so much.
We can.
All right, so let's look ahead. It's really a conversation about exploring palliative care, advanced care planning, and end-of-life care for people of color. That's us, guys. All right. All right, so just to set the tone of the conversation, I believe the heart of living and dying are the things that that drive us. So our family, our life, our friends, where we find purpose, our experiences, our memories, our relationships, the dynamics, our contributions to our greater society. I believe all of those things are just as important as how we live as how we die. And so I want to kind of just set the tone a little bit deeper about what does it mean for us to consider death a part of living? I think as a culture, and I'm gonna make blanket statements, so in generalizations, but I also understand that we are not a monolith people. We have diverse experiences and diverse perceptions. So I will make blanket generalizations, but I do understand there are variations as well. So please feel free to share that if I don't add that to the discussion. But one of the things that I know to be true is that oftentimes when we talk about death and dying, it can be perceived as something that is a failure. It is what we are avoiding. We don't want to see it. We don't want to talk about it. There's a perception if we think about it or if we talk about it or plan for it, then we are calling it to existence. that if we think about the possibilities of those kind of things, or we talk about decline, that there's a possibility that we are manifesting that too. And so I want to challenge that notion today. I want us to think about this conversation today when we talk about advanced care planning, we talk about end of life care and palliative care. I want us to think about us establishing an insurance policy. I want us to think about the fact that if we are stewarding our lives and living quality lives, that also means that we look at what it means for us to dictate and be empowered as we were to die. There are a lot of people who aren't gifted with that opportunity. Some people, of course, pass away tragically, and those kind of things happen where we don't have those narratives. But if we were to be gifted with what our life will look like, with those conversations about who would be around us and who would make decisions and those kind of things, what would that look like? How do we change that narrative within our community? And so that's what we want to talk about. So there are a lot of things that have been said about whether it's hospice, whether it's palliative care, whether it's advanced care planning. The people have stories. People have experiences that we've heard, we've seen. So I want to take an opportunity to hear from you guys. What are some of the things that you've actually heard about hospice or palliative care? And let's see what's fact or fiction. I'm going to stop sharing for just a second so I can look at y'all. What are there things that you've heard?
I've heard that palliative care mainly focuses on pain management and symptom management.
All right, can I call you Miss Tony? Is that okay?
Mm-hmm.
So Miss Tony, you're absolutely accurate. Palliative care focuses on pain and symptom management. That is actually a fact. That's a fact. Palliative care focuses on pain and symptom management. Anything else? What have we heard?
I was going to say that another thing that I hear when I try to talk to patients about, especially Black patients, about palliative care, they're like, oh, you're giving up on me, or I'm going to die. I'm not ready for that yet. So it's just automatic, like you're stepping into death by just getting palliative care services.
Absolutely. So that's probably the biggest one. You'll see a slide in my deck. One of the things people often assume is that I'm the Grim Reaper because we're with palliative care, that palliative care is about death. But it's actually the exact opposite. Palliative care is about life. Palliative care as a specialty is really focused on quality living, meaning that you can have a serious illness and be treated by palliative care, but also still be pursuing curative treatment. It is not end of life care. Oftentimes people misunderstand, or it's even explained wrong if we're honest, that hospice and palliative care are one and the same. And what actually is different is that hospice is a type of palliative care. So what that means is that they are a service that focuses on holistic care, meaning we're going to take care of we're going to take care of your mind, your body, and your spirit. And so that means that we're looking holistically. So hospice does that as well, but palliative care does that, and that's appropriate at any stage as long as you have a serious illness and we're trying to palliate those symptoms. So we're trying to give comfort to those symptoms. So Lisa, that's a good one. Anybody else? What other myths do we have? Things, or maybe they're not myths. Maybe you think it's true. What are the things you've heard?
In taking care of my grandmother, I got the impression that the palliative care was only going to be for a certain amount of time to get her to a certain point.
So that's, go ahead.
This is when she was going through pancreatic cancer. And I didn't quite understand that. I couldn't understand it as it relates to me, because for me, if I'm going to pursue palliative care, I don't want it to just be for 3 months. I may need it for longer than that. So how do we know? How do we get it for as long as we need it?
That's a great question. So there are different types of palliative care and different levels of palliative care. So the reality is that palliative care is a little different than some of the services like hospice that have a standard prescribed set of service that you have to receive as far as like longevity and duration. So palliative care can look very different depending on your setting. So we have inpatient palliative care where it's short term, it's really dedicated to your comfort while you're in the hospital. But then community-based palliative care can be in your clinic or be provided at your home or like in a nursing facility, those kind of things. That can look very different, and it can vary greatly depending on who's providing the service. So ideally, we want palliative care to be provided across the duration of our disease. So that means that it just looks different depending on what stage I'm in. So early in my disease, palliative care may not be seen as often. It may just be to kind of check in, see how I'm doing, establish a symptom management routine, maybe see the social worker for emotional comfort, the chaplains for spiritual comfort or assessment. And what I need, I get, and what I don't. And so maybe on an as needed basis. But as my needs increase, then my frequency and duration with palliative care should also increase. And so that can look very different depending on the service and depending on who's providing for it, and then also who's paying for it. And so that's probably where in the 3 months, I'm not sure who was the payer for that, but sometimes insurance programs will do palliative care in episodes. So it's episodic, so like 3 months based on the need, but you should be able to reevaluate and then get access. But we're gonna talk about that in just a little bit too, a deeper dive. That was really good, Ms. Juanita. Anybody else? What have you heard about palliative care or hospice or end of life or advanced care planning?
So it's my understanding that hospice comes into play when you're done with active treatment. So whatever active treatment looks like, and that hospice care is predominantly designed to manage your pain as you transition.
Yes,
but does
and no.
not help with things like meals or bathing or.
You're absolutely right. So what hospice is designed to do is, once again, palliate symptoms similar to palliative care. So, but what's unique about hospice, it is a benefit that is designed specifically for those with a terminal disease, meaning that based on assumptions, right? They're not God, they don't have a crystal ball, but based on assumptions with the medical insight, that it is expected that if a person is referred to hospice without intervention, it is anticipated that they would pass away within 6 months. Now, there's a caveat to that. Hospice has also opened their scope a little bit more, where they have started to expand. Medical advances have grown so much that there's some people who are on hospice for more of like what we call a chronic terminal illness, meaning that their progression of their disease would be much slower, but we know that they won't ever be free from the disease. And so they may be appropriate to hospice as long as they have a continuous decline, even if it's slow. So that's a little bit different. But traditionally, when we think about hospice services, it's really for people who are no longer pursuing aggressive treatment for whatever the admitting diagnosis is. And that's really specific. So that means if I am on hospice for cancer, that doesn't mean I can't have treatment for my diabetes. It doesn't mean I can't have treatment for all those other things. It's really only for the admitting diagnosis. Can I not have aggressive treatment? Doesn't mean no treatment. It just means curative aggressive treatment. So that's chemo, radiation, immunotherapy, those things. But I could even in some hospices do a blood transfusion. I can even in some hospices do paracentesis and thoracentesis if it's going to make me comfortable, which is normally perceived as aggressive treatment. And so we'll talk a little bit more about some of the interventions that can be provided. But a lot of people think that hospice is also going to come in and do everything. And that's not the case. What hospice will do is provide, and I'll talk about the scope of hospice, but hospice will provide an aide to come in and help do showers and changing clothes and that kind of thing. They'll provide DME, but they won't provide a long-term care, which is food, the things, supervision on long-term, unless of course you're, on continuous care. We'll talk about that. So that is a really great point. So anybody have anything else that's burning, just as far as a myth or a thought, before I jump ahead a little bit? Okay. One of the things that I hear all the time from patients, specifically Black patients, is when we talk about advanced care planning, is that people are afraid to set a plan because they think if I put these things in writing, they're not going to take care of me. They just going to give up on me. They're not going to do anything. So people are reluctant to do advanced care planning. And then something else that I hear is that if I do anything like organ donation or these kind of things, if something were to happen, they just gonna let me go to get my kidneys or those kind of things. And so it's really important that it's really important that we try to dispel those myths and get accurate information so that we can be informed and really empowered to do what we need to do in regards to care. So I'm gonna share again. All right, you guys can see my screen? Perfect. All right, so I want to talk about advanced care planning. And so how many of you guys are familiar with advanced care planning? You can just wave your hand like this. Okay. So when we think, oh, we have a question. Miss Gloria, did you have a question, or were you just raising your hand to say you understand? Uh-oh, you're on mute. Can we unmute Miss Gloria?
I know sometimes she has a little difficulty logging in, so I don't know if she made a mistake or if she wanted to raise her hand.
Can you hear me now?
Yes, ma'am.
My statement was, it was my understanding for hospice is that they said that you had a diagnosis of 6 months or less to live.
Right. And so that technically is the term. And so basically, if you look at the CMS guidelines about hospice, it basically defines terminal as 6 months or less. But here's the thing, if you have what is perceived to be a terminal diagnosis, but you are actively declining and it's a slow decline, you still meet hospice criteria. So for example, I've had people say, well, if you meet that 6 months, they're gonna give you some morphine and take you on out of here. That is not the truth. I've had patients on hospice a year. I've had patients get off of hospice and then get back on hospice. I've had people go on hospice and get off and then never go back for like a year, 2, 3 years later. It really varies based on your individual circumstances and your admitting diagnosis. And so each diagnosis that a person can be admitted for hospice has different criteria for payment based on CMS. And so, yes, that is true, but also no. And so it's really important that when a patient, like when we have patients that are referred to hospice, one of the things that we want to make sure that patients understand why we're referring to hospice and why we think it's appropriate for them. And so for some of our patients, we're referring them to hospice not only about their prognosis, but also about their needs. And when we think about quality of life and what that looks like for them, is that the best place, the right level of care to meet that need? And so I'm going to talk about that in just a second or two, okay? But that was a great question, Ms. Gloria.
Can you be on hospice and still undergo treatment?
So it depends on what diagnosis you're on for. So say, for example, if your admitting diagnosis is cancer, you cannot be on hospice and receive chemotherapy or radiation or immunotherapy. But say, for example, I'm admitted to hospice for COPD, but I also go to dialysis. I could still go to dialysis and still be on hospice for COPD because they're not related to my terminal condition. So technically, I'm receiving life-saving treatment for my dialysis, but I am not receiving life-saving interventions for my COPD. Does that make sense?
Yes, it does.
Okay.
And when you enter hospice, does your palliative care stop? I mean,
It
like if you
does.
have a palliative care doctor, does that relationship stop because now you're in hospice?
So those two different questions I'm going to answer. Here's the first thing. If your palliative care team will stop, right? Because hospice is a level of palliative care. So it's considered a duplication of services because technically we should be doing the same things. However, say, for example, you develop a really great rapport with your palliative care physician or even your med-oncologist. Most people don't know this, but your med-oncologist and your palliative care physician can stay on in your hospice care for care plan oversight, or even your treating provider on hospice. And so we have patients often who maybe they've already gone to hospice, but they want to come in and see the doctor. That's permitted based on the scope of the visit. Okay. All right. So when we think advanced care planning, it's really about planning ahead for future healthcare decisions. If a sudden unexpected event like a car crash or illness happened and you were left unable to communicate and make your own healthcare decisions, and others would need to make decisions for you. And so when we think about advanced care planning, it's a process. It is not a one-time conversation. One of the things that I think is really important, I tell people often, when I think about advanced care planning, I think about it as one of the most critical things that we can do to address equity within our healthcare system. And what I mean by that is that, for example, there are a lot of people within our healthcare system that do not know what they want and care is happening to them rather than to be part of their care plan and their care system. The care team is around them. They're not part of what's happening. They don't know what's going on. Well, when we do advanced care planning, we ask patients, what are your goals? What are your values? What's most important to you? What's driving their decision-making within the understanding of their illness? And so advanced care planning helps to make sure that, number one, you know what's important to you and you know what you want and you know how to define what quality of life is to you and what things you will or wouldn't be open to. And then also can advocate for yourself so that your care team knows that, but also the people that you love and the people who would need to make those decisions for you also understand those things. And so a lot of times, especially when I was in acute palliative care, which is in a hospital setting, I would have families that would be ripped apart at the bedside because we're arguing about what to do with mama. You know, mama's declined really quickly, and somebody thinks that, you know, if don't, you know, leave mama on the machines, it's gonna get better. And then somebody's like, my mama wouldn't want to be like that, suffering. And so the families are torn apart because there's been no communication about what do we do if something like this were to happen. And so it's really important that we have conversations with our family and with our care team about, number one, what are the things that I should be thinking about? And as humans, it's as easy as, if my heart stops, what happens? It's as easy as who makes decisions for me if I'm not able to make decisions for myself. But also, if I'm in an irreversible condition, what would I want to happen? And some of those things are just decisions and things that should be talked about. And it's really important. I often tell this story when I'm talking about advanced care planning, just for perspective. I'm an only child. My mama loves her baby and I love her. And so one of the things that I know to be true is that my perception doing this work and serving near people when they are declining and at end of life has given me a very keen perspective about what it is to live for me. And so I have a very clear perspective about what that is. And so I've placed it in writing and, you know, my husband understands, but my mama does not agree. Okay. She's made that very, very clear. She does not agree. And so I had to sit down and have a conversation with her and my husband and show her in writing, because I am 100% certain if something were to happen to me, she would have me in a glass box like James Brown. Y'all know when he passed away, they had him in that box and he was kind of on tour. They were taking turns where he was going to go. That's exactly how it would be. If there was something that could hook me up, I would be there, right? Out of her love for me, even if that's not what I wanted for myself. And if my husband were to do anything to address what I thought my goals were without living in that condition and not wanting to be like that, she'd probably say he was trying to take me out for the insurance money. And so I had to make sure that I had a clear conversation with the both of them about what my decisions were and what those things mean to me, so that for the sake of my children, if something were to happen to me, they would have peace. I keep on my desk, I can't reach it without getting out of the frame, but I received a card from a family when I was a really young social worker, just early in this work. And I had a really difficult patient. He just was so awful, y'all. He just was crusty and crappy and just mean to everybody. But I just, you know, when you're young, you're like, I can keep trying. I'm gonna get him. I'm gonna make a difference. And he just was horrible. But I kept at it. And his family, we ended up having multiple conversations. We were able to eventually get him transitioned to hospice care, and he passed away peacefully at home with his family. And months later, I get this card from his daughter saying, "Thank you for giving us what we didn't know we needed." And that is what I think about advanced care planning. I think it is a gift that we give the people we love, and they won't know the impact of that gift until they're on the other side. Because what it does for them is give them the opportunity to hear our voice, say what we want, versus them having to make the decision about what they should do. I firmly believe the people that we love will always have grief. Grief is the price that we pay for love, right? So they will always grieve us, but they do not have to have guilt. And so when we do advanced care planning and we do it properly, then they're left with instructions and carrying out our decisions versus having to feel like, well, what should I have done? Should I have done more? Would they have wanted this? Well, what did it, you know, all that. And then that weight is something they will always carry. I see a hand. Let me see how I get there. Michelle?
Hi, Queen. So I just wanted to piggyback on what you said. I was first diagnosed with breast cancer in 2020 with stage 1, and then recently re-diagnosed in 2022 with stage 4. And I'm 39 years old. And the week after I was diagnosed, I actually had my funeral director come by and I planned my whole funeral. And when I planned my whole funeral, I picked my casket out. I told her what I wanted. I told her what I didn't want. And I had, prior to when I was first diagnosed at 36, I had made sure that all of my affairs were in order, because the same thing, I wanted to take control back of what I could control.
Absolutely.
And I want, I'm a mother of two. I wanted it to be an easy, one less thing that my family had to worry about, because they already are dealing with the fact that the mom has cancer at 36. I have a 6-year-old son and a 6-year-old daughter and a husband, and they're all trying to navigate, and now everybody has to take care of mom. I didn't want them to feel like now here we have to deal with something else. So even like my assets and stuff like that, I put stuff in trust. I put stuff, had my lawyers add my husband and my kids' name to all of my properties to make sure that probate court is not an option. And, everyone looked at me like I was crazy because they felt like I was killing myself, right? And I tell people all the time, I can go outside and get hit by a car.
Absolutely.
I can go to sleep and not wake up. So cancer is not the thing that will kill me. Sometimes we get stuck in that mind where we're fearful of something that we know that we cannot change. And death is one of those things that we cannot change. Everyone is going to have a death date. There's nothing, no one has found that golden ticket yet. So why are we so fearful to acknowledge it and at least do it the way we would want to do it?
Yeah.
So I agree with you.
I just appreciate you sharing that and just being, number one, kudos to you, but also like we see you and thank you for being here and sharing that with us. And we're sending you positive vibes and prayers and as well. But I think what's so powerful about what you said is that like, it's about maintaining control. There is so much in this situation that we can't control. We can't control how we get out of here. We can't control what takes us out of here, in most cases. And so the reality is that this is something that we can really dictate and say, hey, this isn't, it's hard. I won't minimize the difficulty of having to think about all of these things, but the value of what it is to be able to do that, I think is so beautiful. And it's also such an intentional act of love that even when we are not here, our children and our family will feel that love from us. It's and I'm speaking from experience of having sat and planned and been able to flip through a book to know what I should have done and what song we were supposed to play, and the relief of that I didn't have to worry. That uncertainty when I was clouded with what life looks like now was a gift. It was like a hug from the grave to say, hey, I still got you. And I think that's what, as difficult as it can be, that's what I think advanced care planning is. So thank you so much for how intentional and deliberate you have been. And thank you for sharing that with us. So let's see. So I want to get in a deeper little look at advanced care planning. So we kind of know like the core components, okay? So, I think when we are trying to establish our advanced care plan and really doing, different things, there are a lot of different tools out there. And so even if we're going to use any kind of tool, any kind of resource that we can find online, the most important thing is conversation. My family cannot stand that every time we are together, I at least bring it up once. I just check in. They think I'm morbid, they think I'm crazy, but I at least check in and be like, hey, by the way, if something were to happen, what's going on? What would you want us to do? How would you want us to, handle things? And so there are a lot of different tools to help spark that conversation there. And I have a resource list at the end that I can share that help you walk through that in your decision-making for yourself. But I'm going to use a really personal example about how this made the difference for us. And so in my family, I'm an only child, but my mom is the one of three. And my grandparents are like my best friends in the whole world. Like they are my people. I was that weird kid who was always with their grandparents. And so I was old too, and was hanging out with Shirley and them, when I should have been doing something else. And so I had these conversations often with my grandmother about as she got older and I could see she getting weaker, about what would she want us to do? And we would get more in depth and more in depth. And we had a very frank conversation about what her perception of quality of life was in regards to nutrition. Because, Black folks and food, it's a big thing. It's it's an act. How she showed love to her family was to make a meal. And so she had started to lose weight, and we could tell that her appetite had completely dissipated. And so she had started to have episodes of calcemia. And so she at that point was very adamant. She was 87, was very adamant that, I ain't even going back for scans. They perceived to be some type of cancer. They wanted to have a biopsy. She was like, I'm not doing that. So she was like, whatever it is, I'm not doing anything. Well, she ended up going to the doctor's office and her labs were just all out of whack. And the doctor was like, I can't even send you home. You have to go to the hospital. So we go to the hospital, and while we're there, the doctor's like, we have two options. I can give you a feeding tube and you'll probably live for years, but you'd be dependent on this feeding tube. Or we could do nothing and we can just, send you home on palliative care and you be comfortable. And we don't know how long it'll take, but you'll pass away. And so my grandma was like, oh, well, let's go on to the house then. And my family flipped. They were like, this is not the will of God. This is not like you. This is not it. We don't do this. Like, this is, you just trying to, this is whatever. They were like, she's depressed. That's the only reason somebody would do this. And so I was gifted with the remembrance of conversations that we had. And I was able to call back and be like, hey guys, do y'all remember when we were talking about and grandma was like, if I can't eat, I don't want to be here. Or when she talked about what it meant for her to be quality of life and what it meant for her if she were to pass away, where she would want to be and what she would want that time to be like. And so she was able to participate initially in that conversation with us as we talked about it as a family, as difficult as it was, regarding what she wanted. And ultimately, what we were able to do was go home on hospice, where she went to her home that she loved, surrounded by the people that she loved, and dictated what that time looked like. And we were blessed with 3 beautiful months of her still bossing everybody around, telling them they weren't cooking right, even though she was barely taking anything in. But if she wanted ice cream, she ate ice cream. And if she wanted cake for breakfast, she ate cake for breakfast. But that 3 months was dictated solely by her. If she didn't want to see you, she didn't see you. If what she wanted to listen to, she listened to. And we were gifted with a transition for her. She passed away in her home after having what she wanted, which was communion, singing Dr. Watts hymns, and her whole family surrounded by her. It was one of the most heart-aching experiences of my life, but also one of the most beautiful experiences of my life. She left holding her husband's hand of 60 years. And it is something that we were all gifted with, that as heartbreaking as the absence is, when I reflect on that time, it's beautiful because we knew we did exactly what she wanted us to do. And so I don't have the guilt. I got grief, and that grief is real, but I don't have the guilt. And so that's what I think about when we think about the conversations about end of life, when we think about talking to our care providers, when we think about talking to our family and friends about these things, is that it helps us really to dictate and take control in a space when we don't really have any. And so we know it could be more difficult when to have conversations when people have Alzheimer's or different things like that. And so we want to have the conversation as early as possible. Advanced care planning is appropriate for anybody over the age of 18, any human. You don't have to be sick. Anybody, okay? I can't see the chat, so. Okay, and so I want to be a little more specific about what the components of advanced care planning are. And so we have advanced directives. So advanced directives are literally the written components of advanced care planning. So think about the legal documents that basically put the things that you want and the instructions that you want and make it law or make it legal, okay? And so states have different documents. For the most part, most states have what we call either a health surrogate, or a medical power of attorney, or a healthcare power of attorney, or a healthcare agent. And so they'll have some variation of that name in most states. Excuse me. And basically what that does is it gives authority for that person to make decisions for you in the event that you're not able to speak for yourself. And so one of the things I get all the time was that I don't need nobody running me, and people will try to take over. But it's really important to note that a medical power of attorney is only in effect if a physician says that you're incapable of speaking for yourself. So that means even if you're making bad decisions, you still get to make bad decisions, unless the doctor says you're incapable of making decisions. And so this just gives us an insurance policy to give someone authority to make those decisions for you. In most states, you're also usually able to designate 2 alternate agents, meaning that in the event that the person you designate is not available, someone else can make those decisions for you. And one of the things I like to really highlight is that people often will think it's about relationships. So for example, because I'm married, it has to be my spouse. And that's actually not the case. What you want when you're thinking about who's going to be your healthcare agent is, who can I trust to make the decisions that I want them to make? So for example, if my husband doesn't do well under pressure, or my mama's not going to do what I want her to do anyway, I'm not going to set up for failure. She's not on that list at all. I have not a stranger, I have literally a non-relative listed, and my mama is nowhere on the paper because I can't trust her to do what I want her to do. And I don't want her to be in a situation where she's forced to try to decide. Okay. So it's not about relationship. It is about who can do the things that you need to do when you need them to do them. Also, your oldest child might not be your brightest child. You know, your husband might be super cute, your partner might be super cute, super fine, but they just may not do well under pressure. So if that's the case, you want something to give the authority to someone else, because like in the state of Texas, if I don't have a medical power of attorney and I don't have anything in writing designating that authority, automatically my husband would have the authority to make those decisions. So say we're separated, say, things are going awry, then he still would make those decisions even if I don't have anything else in writing. So it's really important that you do that. Okay. A medical power of attorney does not have to be completed by a lawyer. And so people often think if I'm going to do directives, I have to have a lawyer draw all these documents for me. And that's actually not the case. Most states allow for them to be completed by a notary. And some states even allow for witnesses to just help sign to execute those. But there are a lot of websites like LegalZoom and those kind of things that can help execute some of these documents. And actually, most of your healthcare providers will be glad to help make sure you get these documents in place at no cost. So why is an advance directive important? And so because we all have the right to own our choices and have those choices honored. So, we're at a place where we know as in society, we don't always get the support and respect we deserve in healthcare systems. And so I believe any opportunity that we are gifted to make sure that our rights, our choices are honored, we take those. And we should be informed and educated about the appropriate avenues to do so. And then it's also really important that the people who care about you will be they'll be grateful to know what you would have wanted if it's ever needed. And then also doing later, like if we wait, it could be too late. We don't ever know. I could fall, I'm clumsy. Actually, true story, I was playing basketball with some kids, ruptured my complete ACL, had to be taken by ambulance to the hospital to have surgery. Literally, just playing basketball. Anything could happen and we just don't know. And so we should always be prepared. So we're going to talk about the different types of advance directives. And remember, these can vary a little bit by state, just by name, but really the content of the documents are usually the same across the states. And so the first is a medical power of attorney. In some states, this is a separate document. In some states, there's a document that's called a post, which here I have the medical order for scope of treatment, but it's the same thing as a post. And those things are covered in one document, just cover everything. But I'm going to kind of tease out the different directives just so that we can be clear. So we've talked about the medical power of attorney, but then there's also what we call a living will or directive to physicians or family. And so the living will, to not be confused with like a general financial will where you're, allocating your resources or assets to someone. This is a little different, not little, a lot different. The directive to physicians covers really two major issues. It's in the event that I am in an irreversible condition. So like think I'm on a ventilator and maybe I've been trach and pegged and I don't know I'm there and I'm expected to not return to my previous level of function. And this condition is irreversible. So I think like that means that what would I want the team to do in this situation? Would I want them to provide comfort care or leave me in the vegetative state? Okay. And then the other is if I have a terminal condition, meaning that I'm expected to pass away within 6 months, would I want to have comfort care or would I want to have care to keep me alive? Okay. And so that's all the directive to physician covers is those major things. And then we're able to add some other elements. So say, for example, I have a really clear perspective about blood products. Think of like Jehovah's Witness, some of them don't receive, well, most of them don't receive blood products. And so I may want to add that, or maybe I have a very clear perspective about dialysis or ventilation or artificial nutrition. I can also add those parameters there. And so this document really it's to help the doctors and team know what to do. It's to help your family know in these certain situations, what do I do? Okay. And so if I were to say any two documents every human should have, it is a medical power of attorney and a directive to physicians. Any human over the age of 18, okay? And then next we have what we call a DNR. And so this one brings up a lot of discussion usually because of course, when we think about do not resuscitate orders, they can vary greatly by states. And so in the state of Texas, we have what's called an out of hospital DNR and of course, a do not resuscitate order. For the sake of conversation, I'm just going to blanket them together, just talk about what a do not resuscitate order does in general. And so basically that means if our heart stops, what do we want them to do? And I try to simplify it that way just to give better understanding, because I think oftentimes I have patients say, well, I don't want to talk about that because if I do, nobody's going to do anything for me. Nobody do any care for me. And so it's really important that we have a better understanding of what DNR actually mean and what it does, because a lot of times we have a perception about CPR and we think like Grey's Anatomy. We think, that people have CPR and they just get up and walk away. And that's really not the case. And so oftentimes I have patients who have conflicting perspectives about resuscitation because they feel very strongly about their quality of life. Like maybe they wouldn't want to be on a ventilator. But in most cases, patients who have a serious illness, almost 82% of patients who have more than 2 comorbidities actually end up ventilator dependent. And so it's important that we really talk about that from an informed place. And so maybe you're open to trying resuscitation. You were like, hey, give me a good go, right? Yeah, let's try it, see what happens. And if I end up on a ventilator and you're not able to withdraw that, then maybe that's when that's it, And so I think it's really important to have those conversations with families just to be aware, because it does look different on a really healthy person versus someone who may have comorbidities. And then the post. And so I have medical order for scope of treatment because here in Texas, we just literally last week, the law was just amended to now be post like the rest of the country. And so of course, Texas just, we got issues. But a post is a physician's order for scope of treatment. And what it does is a document that is really descriptive. It basically picks a path of care. It basically says, I want to make sure I have access to all full treatment, or I want to make sure I have access to some treatment, but maybe I don't want to be on a ventilator. So maybe I would be okay with, having CPAP or BiPAP and having an airway support, but I don't want to be on a ventilator permanently. Or maybe I'd be okay with like some short-term artificial nutrition, but I don't want a G-tube. So maybe I'd be okay with TPN. And so it allows us that opportunity to think about some of those things in a really clear way. A post has to be completed with a physician or a member of a clinical team. So like your social worker, your nurse, or someone, or APP, someone like that, to help make sure, because it includes a lot of medical terminology. And then of course we have our durable power of attorney. And this can vary. It has a lot of different names in different states. But in the state of Texas, the durable power of attorney. But basically what it is our power of attorney that governs our assets, our financial assets. So think about where we guarantee to like have a person who's going to dictate what happens financially for us. If we're not able to, your bank, most banks have a durable power of attorney attached to your account where you can submit that about who you would want to have access to your financial resources. Okay, so that covers property, assets, real estate, all that kind of stuff. That is also different from a will. Okay, so we have to know that even though we have a durable power of attorney, that gives someone authority to access and make decisions on our behalf, but a will dictates who receives those assets. And if we don't have a will, a lot of times, depending on your state, everything gets tied up in probate. And it's so sad to see families lose the home that grandma and them worked so hard for because there wasn't a plan in place. All right, so any questions about that? I know I covered a lot. It's like fire hose. I'm just kind of.
Yeah, I told everyone that we'll hold the questions till the end.
Okay.
That's okay.
Perfect. And you'll have to be my timekeeper because I'll be talking and just going.
Yeah, we're at 6:49. We're supposed to end at 7, but we'll just have you go through the slides and then we'll ask questions at the end. So
okay, perfect. All right. So, so we've covered all that. I should have been going through my slides, didn't realize that. So here's the thing. This slide just really, I feel like speaks to experiences that I've had with patients where literally, where somebody said, if I'm ever on life support, unplug me, then plug me back in and see what happens. Like, see if it works, right? People really say that, like, give it a try, see what happens. And the reality is that all of it is a personal choice. But we lose that opportunity to navigate those choices if we are not part of the conversation. And the reality is that some things, once we start, we can't stop. So it's really important that we know that and what that can look like. So we've talked a little bit about comfort care just before, but I want to kind of take a deeper dive because I think this is really where I believe most of the challenges are with our people when we think about just care in general. Comfort care is anything that can be done to soothe you. So it's really about palliating and relieving your suffering. And so it can include, managing shortness of breath or limiting medical testing, or even not doing labs, or providing spiritual support, emotional counseling. It could be medications. It could be complementary treatments, anxiety, nausea, constipation. It's really anything to soothe or comfort any symptom that you may have is what we think of when we think comfort care. And so just to kind of make sure we all understand, I'm sorry my pictures are so pixelated, but palliative care and hospice is really similar, but there are some very important differences. And so I'm going to start with what they have in common. They are both comfort care. They're both services that focus on the entire family, meaning that palliative care and hospice in general believe that it is impossible to care for a patient without caring for the people that care for them. And so that means we provide support to the entire family unit. And so it's designed to reduce stress, the caregiver burden, but even with stress on the individual. They offer complex relief related to serious illnesses and provide physical and psychosocial relief. So when we think about the psychosocial challenges, we mean like the challenges, the practical challenges that people have, if it's resources, if it's emotional distress, but it could be so simple as like trouble paying your light bill. Those practical things are also addressed because it's really relieving any stress or burden that's related to your care. So palliative care is usually paid by insurance or by an individual themselves. And so palliative care is a really new in the grand scheme of like specialties. So all insurances may not cover palliative care the same way. They may cover it in different components. And so almost 100% across the board, most insurances will cover for you to see a palliative care physician. All of them may not cover for you to see an interdisciplinary team. And so it's just really important to know your benefits, but your provider should also be able to clarify that for you. Palliative care is appropriate at any stage of disease. I actually personally believe that every patient should have access to palliative care at the moment of diagnosis. And then also palliative care can be provided at the same time as curative treatment. Actually, research shows that when patients have access to palliative care, they actually have an improved expectations and they improve outcomes. And then also palliative care, most often where people see it across the country is in a hospital system. And so most hospitals have some level of palliative care, although their palliative care is expanded and grown greatly into the community. So, and then there's hospice. So we know that hospice can be paid for by Medicare, Medicaid, or insurance. And then also hospice is specific for patients with a prognosis of 6 months or less. And then it excludes curative treatment, as someone mentioned before, and it can be provided anywhere a person calls home. So that means literally anywhere. So a nursing facility, assisted living, your mama house, your friend house, a homeless shelter, wherever you call home. Okay, so palliative care, just a little bit of a deeper dive, it's really holistic care. And I can't say that enough. It is literally looking at every facet of life and saying, how can we give you comfort? One of the things that we know is that the symptom burden is taxing and your body holds on to that. So we want to help relieve that. So we think about your mind, your body, your social support systems, your spiritual needs, your daily living, your desires and goals, and your illness. And to really just improve the quality of your life. And so it's not about prognosis. It is about where you are, and it's individualized and patient-centered. So I reached the end of my slides with some resources, and actually I didn't update those. So I need to make sure I'll make sure Miss Victoria can get a copy of those updated resources because I have a list for y'all. So one question that was in the chat, are palliative care physicians difficult to find? So they can be. The reality is that although the awareness about the specialty has drastically increased, there's still a lot of gaps in regards to palliative care services. So if you're ever looking for a palliative care physician, there are two things you can do. You can, number one, talk to your provider because that would be really helpful. They'll probably have a referral person they like to use and have a good relationship with because it's really important. Palliative care is a collaborative specialty. So we work alongside your team. We don't take you from your team. So you want them to feel comfortable working with your doctor, okay? And most of the time, the palliative care team will feel comfortable, but your doctor may not. And so you want to know, who do they like, okay? But if you're looking, there's a website called getpalliativecare.org where you can find palliative care providers. And then also the Center to Advance Palliative Care also has a list of palliative care programs within the country as well. But I bet, and in worst case scenario, call your insurance, ask them, I want palliative care, how do I find it? Because even insurances are now providing palliative care to their patients because of the outcomes. And it actually shows that it not only improves patient experience and outcome, but also saves money. Because patients aren't in the hospital, they're home and comfortable. All right.
Are there any more questions in the chat? Because I do have a few before we